Okay, good day, everybody. I'll be presenting wound healing and its pathology. So we're going to start with a definition of wound repair or wound healing. So it's basically the repeated attempts to restore the mechanical integrity of tissues. This will help to repair the barriers to fluid loss and infection and reestablish normal blood and lymphatic flow patterns. So the goal of wound healing ideally is regeneration. Regeneration essentially will be the perfect restoration of pre-existing tissue architecture without scar formation, which is usually only achievable during embryonic development or in lower organisms or in certain tissues within the body, such as the bone or the liver. So we'll be looking at the three most important, the three phases essentially of wound repair. So the inflammatory phase, the proliferative phase, and the maturation phase. So we'll start with the inflammatory phase, which is day 0 to day 4. It begins immediately after the tissue has occurred or sustained an injury, and it lasts approximately 4 days. In contaminated wounds, however, it can be prolonged beyond the 4-day mark. The purpose of it is not simply inflammation, but it prepares the wound for successful healing as well. And it begins with achieving hemostasis, where bleeding is stopped and inflammatory cell recruitment follows. The removal of bacteria then happens, and devitalized tissue is also removed. This happens at the level of the neutrophils. And following this, there is the release of cytokines and growth factors, which initiate the proliferative phase. The failure to appropriately regulate this phase is what will contribute to a chronic non-healing wound. And the sequence of events is basically injury, hemostasis, inflammation, chemotaxis, debridement, and then preparation for proliferation. So the characteristics of the inflammatory phase is where there's vasoconstriction followed by vasodilation. This leads to increased vascular permeability and leukocyte recruitment ultimately by the 4-step procedure that we would have covered. So then this follows the cytokine and growth factor release, and inflammatory cells are activated. So in the first part of the inflammatory phase, we look at hemostasis and the early inflammatory response. So immediately after injury, the vasoconstriction will minimize blood loss and platelets will adhere to the exposed collagen through different factors. So von Willebrand's factor, which will lead to platelet adhesion, and the GP2B and the 3A, which factors which will lead to platelet aggregation. The coagulation cascade is then activated, where fibrinogen is converted to fibrin, and a fibrin clot forms, which is stable. This functions initially to stop the bleeding and provide a temporary matrix, which will be replaced later on. It provides a scaffold for inflammatory cell migration, a reservoir for cytokines and growth factors. The platelet-derived mediators, which are involved at this stage, would be the platelet-derived growth factor, the tissue growth factor beta, insulin growth factor 1, epithelial growth factor, fibronectin, serotonin, and thromboxane A2. The next stage that we'll look at is the cellular response during inflammation. So the timeline of the inflammatory cell would be where the platelets are involved initially in the immediate stage, and they function to achieve hemostasis, release growth factors as well. The neutrophils then come, which are 24 to 48 hours after tissue injury, and their role is in bacterial killing and debridement. The neutrophils usually undergo apoptosis after their task is complete, but where there's persistent neutrophilic infiltration, this will persist inflammation and delay healing. The macrophages would be primarily involved 48 to 96 hours after injury, and they are usually the master regulator of healing, where they release certain growth factors which promote healing. Lymphocytes come in by day 5 to day 7, and they play a role in immune regulation. So for the neutrophils, they are the first to arrive. They are involved in chemotaxis via the interleukin 8, which is the most potent chemoattractant for neutrophils, the LTB4 and certain bacterial peptides. They function to encourage phagocytosis as well as ROS production, protease release, and bacterial killing. The significance of this, which we would have covered, is that they play a significant role in chronic wound formation, which is a form of abnormal wound healing. Looking at the macrophages now, which we mentioned was the master regulator of wound healing, they come about 48 hours after injury and replace the neutrophils. They are the most important inflammatory cell associated with wound healing. They coordinate basically every phase subsequent to the neutrophilic infiltration in wound healing. So they will remove the bacteria and necrotic tissue and simultaneously produce cytokines and growth factors, TNF alpha, interleukin 1 and interleukin 6 specifically, and the growth factors, the PDGF, TGR beta, the VEGF, the epithelial growth factor, insulin growth factor, and fetal growth factor, or which is also called keratinocyte growth factor. They also play a role in angiogenesis as well as fibroblast activation and collagen synthesis, which will lead to the proliferative phase being initiated by the macrophages as well. The macrophage is differentiated into two different phenotypes, which play two different roles in wound healing. One is pro-inflammatory and one is anti-inflammatory. M1 macrophages have a pro-inflammatory function, and their cytokines involved would be the TNF alpha, interleukin 1 and interleukin 6, as well as nitric oxide. Following the inflammatory stage, you then move to the M2 macrophage phenotype, where it promotes an anti-inflammatory response, which leads into the proliferative phase, where tissue repair, angiogenesis, matrix deposition, and remodeling is encouraged. When the macrophage transition fails, this is what also contributes to chronic wound development. In terms of the cytokines and growth factors, we would have mentioned they are pro-inflammatory and anti-inflammatory cytokines. Pro-inflammatory cytokines basically prevents the movement forward into the proliferative phase or the healing phase. The anti-inflammatory cytokines would be more so the M2 phenotype, the interleukin 4, interleukin 10. They will limit the inflammation and promote resolution. And these would have been the key growth factors that we mentioned before, and the specific functions that they have, where they act on different components of the healing cycle. So in summary, the inflammatory phase, successful inflammatory phases will result in proper bacterial clearance, proper debridement, resolution of the inflammation subsequently, fibroblast recruitment, angiogenesis encouragement, and granulation tissue formation. Failure of this will lead to persistent inflammation, excessive protease activity, chronic wounds, delayed epithelialization, impaired collagen deposition, and infection. Moving on to the proliferative phase, which is usually from day 4 to day 21, the purpose of this phase is where tissue integrity is restored, and it replaces the temporary fibrin clot that would have been made initially with granulation tissue and an extracellular matrix. The major processes of this phase would be the granulation tissue formation, angiogenesis, fibroblast proliferation, also termed fibroplasia, epithelialization, extracellular matrix synthesis, and collagen deposition. The primary cells involved here will be the fibroblasts, endothelial cells, macrophages, as well as the keratinocytes. The dominant cell during this phase will be the fibroblasts, while the macrophages will continue to orchestrate function behind the scenes through their function of producing growth factors. In terms of granulation tissue and angiogenesis, granulation tissue is basically tissue that has a new capillary network, fibroblasts, macrophages, a loose collagen matrix, fibronectin, and hyaluronic acid. The function of this is that it fills the defects caused by the tissue, provides oxygen and nutrients to the healing tissue, supports fibroblast migration, and it serves as a scaffolding for the collagen deposition later on. Angiogenesis is the process of formation of new blood vessels from already existing vessels, and the sequence of events that will lead to angiogenesis will be the initial insult to the tissue or the vessel, causing endothelial activation, basement membrane degradation, endothelial migration with capillary budding, and then tube formation and capillary maturation. The important mediators here would be these growth factors, which we would have touched on previously. Of note, of all the growth factors, though, the VEGF is the most important angiogenic growth factor. It stimulates the endothelial migration, the proliferation, and tube formation as well. Moving on to fibroplasia and fibroblasts, this is where the fibroblasts will migrate into the wound and become the dominant cell. It's stimulated by these growth factors as well. and it functions to synthesize collagen, produce the extracellular matrix, synthesize fibronectin, as well as proteoglycan and glycosaminoglycan production. It later contributes to wound contraction, where it differentiates into myofibroblasts. The fibroblasts typically begin collagen synthesis approximately 3 to 5 days after the injury as well. The next step in the proliferative phase will be epithelialization. Epithelialization basically occurs where the keratinocytes will migrate and then proliferate, restoring the epidermal barrier of the cell or the tissue. And it begins within hours of the injury, actually, and it continues to happen in the background until proper coverage of the wound happens. The stages of epithelialization will be where the keratinocyte detaches and then migrates across the wound bed. It proliferates on the wound bed as well, and then differentiates, stratifies, and then restores the basement membrane. Usually for epithelialization to occur, you would need an intact basement membrane, a moist wound environment, and a healthy wound bed. Is stimulated by these growth factors as well. And the significance of it is that rapid epithelialization will reduce infection, fluid loss, and helps with scar formation. The extracellular matrix on collagen is then proliferated. So the extracellular matrix components will be collagen, fibronectin, elastin, proteoglycans, glycosaminoglycans, and lamellin, and it functions to provide mechanical support, cell adhesion, cell migration, growth factor reservoir, and signal transduction as well. In terms of collagen, different types of collagen are associated with different types of wound healing. So type 3 collagen will be associated in early healing, and this type of collagen does not provide a lot of tensile strength to the wound, so it's very elastic, and it then differentiates or is replaced by type 1 collagen during the maturation phase, where it becomes stiffer, less elastic, and has greater tensile strength. In order to synthesize collagen, it starts with procollagen being formed and then undergoes hydroxylation, which requires vitamin C. This is why vitamin C deficient patients as well usually have impaired wound healing. It then forms a triple helix, moves on to secretion, cleavage of the collagen, fibril formation, and then cross-linking of the collagen fibers. The growth factors involved in the proliferative phase would be the same growth factors basically that we would have spoken to before, but this slide basically expands on their specific function to each step in the proliferative phase. And here the macrophages are still the principal source of the growth factors that are involved in this phase. To clinically correlate the proliferative phase in terms of days, so at day 4, where the inflammatory phase ends, is where the proliferative phase will begin. From day 4 to day 7, you typically have angiogenesis, days 4 to 14, fibroplasia, days 1 to 4, epithelialization, since it starts at the very point in time where the tissue is injured, days 3 to 21, collagen synthesis, and from there is where we transition to the maturation phase or the remodeling phase. The factors that will delay proliferation or basically affect wound healing would be factors like infection, which prolongs the inflammatory phase, diabetes, which affects the neovascularization, as well as wound healing, predisposing to infections as well, malnutrition, smoking, hypoxia, steroids, any kind of pathology that leads to poor perfusion of the tissue, peripheral arterial disease specifically, and a vitamin C deficiency. Moving on to the maturational phase, this occurs from anywhere between 3 weeks from injury to a year, and it can extend even longer than a year. And its purpose will be to transform the immature granulation tissue into a mature, strong scar. So the major events, the wound starts to contract, the collagen starts remodeling, and then cross-linking. The extracellular matrix remodels as well. The neovascularization starts to regress, and then you have scar maturation. The principal cells involved here would be the myofibroblasts, fibroblasts still, but in a lesser amount, and the macrophages also in a declining amount. The objective basically is not closure of the wound, but basically to optimize the scar strength and the organization of the scar itself. The hallmark of this phase is where we would have stated the types of collagen before. The type 3 collagen will be replaced by the type 1 collagen, which is a more mature, stronger, organized collagen, which will strengthen the scar formation itself. Now, for wound contraction and the myofibroblast, wound contraction, the definition of it is the centripetal movement of the surrounding skin, which reduces the wound size. It functions to reduce the surface area of the wound, decrease the size of the scar, and speeds up wound closure. Fibroblasts, basically activated fibroblasts that possess smooth muscle-like properties. Their characteristics, they will express alpha smooth muscle actin, which will then form actin-myosin contractile filaments, and these attach to collagen and the extracellular matrix through the fibronectin and integrins, and this component in general will generate a contractile force. They typically appear approximately day 6. They will peak around 2 weeks, and they usually undergo apoptosis by 4 weeks. The important mediators here would be the TGF-beta and the beta-1 integrins, as well as MMP3, or stromatolin. In terms of wound contraction, this usually results in a contracture, which is a pathological complication of wound contraction. So wound contraction is normal. It's a physiologic process. Contracture, however, is where you have excessive contraction, and it will cause a deformity and loss of function. So this would happen in terms of burn patients, or patients could develop ectropions on their eyelids or joint contractures as well. Now, collagen remodeling and scar formation. So we would have stated that there's replacement of the type of collagen. So the remodeling would be where you have the early scar, which is rich in type 3. It undergoes gradual degradation and then replacement by type 1. It undergoes cross-linking, and this will lead to the increase in tensile strength. Importantly here would be the function of the matrix metalloproteinases, and this will degrade any excess collagen and remove any damaged extracellular matrix, permitting remodeling of the scar. This is regulated by the tissue inhibitors of metalloproteinases, and basically the balance between these two would either determine if the scar progresses to developing problems like chronic wound healing or poor wound healing, or if it progresses to developing a hypertrophic scar or a keloid formation, based on which one of the two is more active than the other. The scar strength increases rapidly during the first 6 weeks. It plateaus around 1 year. And the final tensile strength is usually about 80%. It never reaches the full 100% of an uninjured skin. All right, so the important thing in this slide is basically that the extracellular matrix is usually remodeled throughout the maturation phase. The MMPs would be degrading any unnecessary collagen. So this will help to prevent a hypertrophic or a keloid formation. As the remodeling progresses, the vascularity and cellularity will decrease, and then that is where you would have the mature scar, which is usually pale in appearance. Right, and this will be the characteristics of what a mature scar should be. They should be less vascular, less cellular, have more organization, have more tensile strength, reduced elasticity. There should be no skin appendages within the mature scar, and is usually more brittle than normal skin. So these two implications would be what we would have spoken about with the MPs and the TIMPs. So where you have poor remodeling is where you have excess breakdown. This would lead to your chronic wounds, weak scars, wound distance. This will be where you have excess function of the MMPs over the TIMPs. Excess remodeling will be the opposite, where you have reduced breakdown and more proliferation, leading to hypertrophic and keloid scar or a contracture. Now, in terms of abnormal wound healing, it is basically the failure of the normal wound healing process due to disruption of the balance between collagen deposition and collagen degradation, resulting in impaired repair or excessive scar formation. The factors impairing wound healing could be either local or systemic. Local factors will include extensive tissue loss, foreign bodies within the wound, bacterial contamination that has persisted, or prolonged exposure to toxins. Systemic factors would be advanced age, diabetes, atherosclerosis, cardiac failure, renal failure, malnutrition, chemotherapeutic agents, or glucocorticoids. The outcomes of this all lead to delayed healing, chronic non-healing wounds, hypertrophic scars, keloids, wound contractures, or wound dehiscence. Here we have a brief overview of hypertrophic scars versus keloids. So a hypertrophic scar is basically a abnormal wound healing that is confined to the original wound. It does not exceed the margins of the scar or the wound itself. It usually regresses spontaneously And this scar forms following a state of prolonged inflammation or where there's excessive tension on the wound and is associated with increased collagen deposition. Keloids, on the other hand, can extend beyond the margins of the wound. They usually do not regress and usually has a strong genetic predisposition. The collagen deposition here shows a very disorganized pattern. The pathophysiology of both, however, are the same, where there's excess collagen synthesis, reduced degradation, and increased TGF-beta signaling with a reduced MMP activity, so you have persistent fibroblast activation. The histology differs, hwhere the histology of a hypertrophic scar, you would have well-organized collagen bundles, numerous fibroblasts, and small blood vessels. In the keloid, it's a disorganized set of collagen bundles, acellular collagen nodules, dense collagen extending within to the deep dermis. Prevention of both of these basically involves reducing wound tension, silicone sheeting or gel pressure therapy, adequate hydration or occlusive dressings, and sun protection. However, first-line management, which are usually conservative managements, are sometimes not sufficient. Additional first-line managements could include the triamcinolone injections as well as cryotherapy for smaller lesions. But where conservative managements do not work, you can proceed to a surgical excision. However, this cannot be done in isolation. Adjuvant therapy must be done afterwards to prevent it from recurring. So adjuvant therapy will include steroid injections, silicone sheeting, pressure therapy, and sometimes in very select cases, post-op radiotherapy. Further to surgical treatment, these are very much adjunctive therapies that would be used if there is either recurrence or inability to control the growth of the scar, essentially. So you could use pulse dye laser, 5-fluorouracil injections, verapamil, bleomycin, interferon alpha 2b, radiation therapy, or onion extract preparations where there is limited evidence for. And the last abnormal wound healing that we'll look at will be chronic non-healing wounds. So this is failure to progress through the normal phases of wound healing within 3 months of the inciting event. The pathophysiology is where there's a persistent inflammatory environment characterized by persistent neutrophils, macrophages, increased cytokines, interleukins, TNF-alpha, excess reactive oxygen species, increased MMPs, reduced TIMPs, degradation of the extracellular matrix, and redacted growth factors. The result of this is where angiogenesis is impaired, fibroblast function is impaired, epithelialization is delayed, and the tissue destruction persists. This is usually seen in diabetics. So for diabetic ulcers, the venous ulcers, and the venous insufficiency patients, pressure ulcers, and chronic osteomyelitis wounds. And the significant thing with a chronic non-healing wound is that there is a malignant potential, where it could form a marginal ulcer. So long-standing chronic wounds, they could actually develop squamous cell carcinoma. So any suspicious wound persisting over the 3-month mark should require a biopsy. And if atypical findings are seen in the initial biopsy, a repeat biopsy should be done as well. Yeah. Thank you.